National Collaborative Center for Determinants of Health. Thank you for joining us for our webinar on the design and modus operandi of a tool based on a reflexive approach. The name of the tool is Reflex-ISS. Today we'll be talking about the development of this tool as well as how it's being used in public health practice. Please note that our webinar today is being recorded. So moving to slide number 2, I see that we have a number of people on Adobe Connect. If you're on, please tell us your name, your organization, and where you're dialing in from. We'll also love to hear if you're joining us with a group. You can also use the chat box at any time during the course of the webinar to share resources or ask any questions you have of our presenters. Now on slide number 3, that is me. If you have any problems during the course of today's webinar, you can send me an email and we will try to help you out. We also sent out backup slides this morning, so if you are not on Adobe Connect, you can use those slides to follow along today's presentation. I'm pleased to be joined today by two of our presenters, Anne Guichard and Karen Noor. Anne Guichard completed her PhD in public health from the University of Montreal and the Université Paris-Descartes. She is an assistant professor in public health in the Faculty of Nursing at Laval University. There, she teaches health promotion and supervises undergraduate students in nursing and postgraduate students in community health. She has over 10 years of experience working at the Institut National de Prévention et d'Éducation à la Santé in France. Her research projects focus on capacity building in public health organizations to ensure that social inequalities of health are included in their interventions, as well as in the development and evaluation of interventions using information and communications technology. She is a regular research member of the Renard team studying knowledge transfer related to social interventions in the education, health, and community sectors, and is also a member of the Regroupement Stratégique Inégalité Sociale de Santé at Quebec's Public Health Research Network. Thank you for joining us today, Anne. Our second presenter is Karen Noor, who holds a PhD in public health from the University of Montreal and acts as service manager in the threat management and environmental health team at the Montérégie Public Health Unit. She is also a clinical professor at the Department of Social and Preventative Medicine at the School of Public Health in the University of Montreal, and an associate professor at the University of Sherbrooke, and a member of a number of research groups in Quebec. Throughout the years, Ms. Noor has developed an evaluative research expertise in public health programs as well as in frontline services, and her research projects focus on program implementation in practice settings involving cross-sectoral partners. Thank you for being here with us today, Karen.
Thank you.
We're now on slide number 5. We know that you're joining in from around the country, so we'd like to have a sense of who is on the line with us today, and Anna's going to open up a poll, which you should see on your screen shortly, and you should be able to vote there. So I'm speaking today from Toronto, and our presenters are calling in from Quebec. Great, thank you. So I see we have folks in from Quebec, from Ontario, from BC, Alberta, thanks for joining in, Saskatoon. Great. Great to have you all on the line today. Moving on to slide number 6. Today's webinar is brought to you by the National Collaborative Center for Determinants of Health, and we form a network of 6 national collaborative centers for public health funded by the Public Health Agency of Canada. The entities are spread out across the country, and collectively are mandated to support public health practice in a range of public health areas. As you can see on slide number 6, we have a center focused on Aboriginal health, which is out in BC, in Prince George. Another focused on environmental health, and that's based in Vancouver. We have a center focused on infectious diseases in Winnipeg, one on methods and tools for knowledge translation and evidence-informed decision-making in Hamilton, as well as the center, the NCC for Healthy Public Policy, which is based in Quebec. On slide number 7, our particular focus at the National Collaborative Center for Determinants of Health is to support public health practice related to the determinants of health and health equity. So we work to share what's known about what public health practitioners and organizations can do to help reduce the gap between those who are most healthy and least healthy. So on slide number 8, today's webinar is part of a series of 4 webinars which we're going to be doing in 2017-18. And over the course of 4 webinars, we are going to be profiling a range of tools which are being used in Canadian public health practice. Today's webinar is going to be offered in English as well as in French on March 22nd. So for those of you who have colleagues who work in French, you can let them know that we're going to be doing the same webinar on March 22nd, which is next Wednesday. And the other 3 webinars will focus on different health equity tools. So just coming back to today's webinar, today we're going to be talking about Reflex-ISS. We're going to be discussing the tool, its application, as well as the structure, and Anne is really going to be walking us through the process of adaptation and testing in Quebec and the work she and her team did to adapt this to the Quebec reality. And Karen is going to be talking to us about how the tool has been applied in a particular public health organization. So we're really glad that we can have both perspectives represented here today. So before I invite Anne to start her presentation, I would like to get a sense of what kinds of, if you're using health equity tools in your work. And if you are, let us know what tools you're using. So we have a poll going up on the screen. So we'd like to know, have you used the health equity tool to support your work? So have you used this particular tool? Are you using other tools in your work, or are you using tools which are not related to health equity? And for those of you who have used other health equity tools, I see about 45% of people have used other tools. I would love to know what tools you're using. You can drop those into the chat box. If you're joining us by phone only, you can reply to the email you got this morning. Great, thank you very much. So now I'm going to move on to slide number 11. I'm going to invite you, Anne, to start off your presentation.
Thank you, Sumi. Hi, everyone. I have the pleasure of speaking about Reflex-ISS today, a reflexive tool to help public health practitioners address social inequalities in health in their interventions. Initially developed in France for frontline practitioners, the tool has been recently adapted to the realities in Quebec. The idea was to create a tool that could be used by health professionals in combination with other initiatives with their organizational environment. Today, I will explain the participatory process used to tailor the tool to the needs of the potential users in Quebec. Of course, I will also demonstrate to you how the tool works. Since English is my second language, I hope you will forgive me if I stick closely to my notes. Thank you. We move to slide number 12. So first, I would like to explain a number of findings that motivated us to create this tool. Although these findings were published in a long time ago, they are still valid and relevant. Also, it is quite clear that addressing social inequalities in health is everyone's business, a priority for every level of the care system, not only a prerogative of the health system. There is still some controversy about public health's role in the matter. However, some researchers found that interventions implemented without addressing social inequalities in health most often end up exacerbating them. There is a general consensus that it is the public health sector's ethical responsibility to ensure that interventions do not contribute to theoretical research and significant increase in the wealth of knowledge about social inequalities in health. Findings show that it's still hard to translate theoretical developments into public health action. There has been more calls for action since the publication of the Ottawa Charter. However, effectively addressing social inequalities in health remain marginal in public health and somewhat invisible at the planning, implementation, and evaluation stages. There is real progress and authentic commitment to act, but there is controversy about interventions implemented by frontline practitioners. Many still believe that actions on the social determinants of health have nothing to do with public health mission, that public health does not have the means nor the legitimacy to act. This consideration often makes public health professionals feel powerless. This is why they have been asking for tools to help them incorporate effective actions into their practices. We move to slide 13. Recently, researchers have concentrated less on defining social inequalities in health and more on understanding the challenges in addressing them. One of the reasons is that our approaches are not adapted to the complexities of social inequalities in health. They are not reflective of the fact that social inequalities in health are a WIT problem. In the literature, a WIT problem refers to a problem that is difficult to define clearly, is rooted in local realities, has no immediate or cookie-cutter solution, has multidimensional causes, and involves stakeholders from different backgrounds. Finally, the problem is resistant to change and requires action based on a collaborative, intersectoral, critical, and reflexive practices. Brassolotto and collaborators found that the challenges faced by public health practice in addressing social inequalities in health are not due to a lack of knowledge, which was what everyone thought for the longest time, but to different perceptions built over time and accepted by practitioners. Researchers call this phenomenon epistemological challenges. According to Jeff Masuda, it is important today to switch to collaborative knowledge transfer approaches that will help determine how do I do this instead of what should I do. Masuda describes a solution that requires stakeholders to engage in a more reflexive practice approach. Slide number 14. Before we continue with today's presentation, let me explain the concept of reflexivity. In an organizational environment, reflexivity refers to an intellectual process that helps to question practices, roles, beliefs, values, and biases professionals have and that promote learning and their application in the practice. In a nutshell, it is all about learning activities and professional development. Slide 15. Based on these observations, a first version of an analysis and discussion tool to assess action on social inequalities in health was produced and promoted in 2010 in France. This grid was created for frontline practitioners and called GALIS. GALIS for Analysis Grid for Actions to Address Social Inequalities in Health. The grid was designed based on three existing instruments to assess the effectiveness of health promotion interventions. The first one, the analysis grid for best practices in addressing social inequalities in health, was used as a part of the European project called Closing the Gap. This grid included 11 criteria to help identify best practices at the European level, so they could be pulled in a database shared with all users. The PRIFI tool was created to determine the potential effectiveness of health promotion interventions and is currently used in the Netherlands. The PRIFI tool is a questionnaire developed to examine different project phases and related resources. PRIFI's strength is that it provides a structured, operational, and practice-based method to support project planning and management. The final tool on which our own work was more specifically based on is an evaluation grid to determine the effectiveness of community health interventions. It was created by the Canadian Consortium for Health Promotion Research. This grid's strength is that it focuses on the qualitative dimensions of projects, on understanding the dynamics of an intervention process and how they are closely linked to the context in which the interventions are being carried out. We move to the next slide. After examining and analyzing the strengths and weaknesses of these three tools, we start to harmonize them. To do this, we relied on two sets of criteria. The first one is a standard criteria on the effectiveness of health promotion interventions. In fact, we hypothesized that any action aimed at reducing social inequalities in health should first and foremost conform with general standard criteria related to the quality of the intervention process, especially those in the area of health promotion. The second criteria is a criteria that could be linked to equity, that is to say, appropriate in addressing the issue of social inequalities. I don't want today to spend too much time on how the tool was developed. For those who are interested, please wait at the end of the presentation to answer your questions or see the reference at the end of the slide. We move to the next slide. In Quebec, the appreciation of the tool's possibilities combined with a willingness of the Montérégie Public Health Unit to act on social inequalities in health provided an ideal setting to tailor the tool to Quebec context, taking into account the characteristics of regional and local public health organizational realities. The approach was based on a participatory development model. Researchers, health professionals, and managers share the responsibility to ensure the project would be relevant and lead to pragmatic results. The process included 3 steps. An exploratory study to determine the key conditions under which the tool should be used, the co-creation and validation of the tool with the potential end users, and the development of useful resources for dissemination and knowledge transfer purposes. Slide number 18. Since professionals and managers were key stakeholders, it was important to involve them in the tailoring process. Consequently, we conducted in 2014 an exploratory mixed method study, including concept mapping, focus groups, and a discussion workshop, and involving 39 local and regional public health stakeholders. The combination of these 3 methods allowed us not only to identify and prioritize a number of key conditions under which to use the tool in the Montérégie context, but also to understand the different realities of different organizational settings and to compare different points of view. Next slide. We found that there was a strong interest in the tool because it was perceived as helping to identify key elements on social inequalities in health at different stages of a project, that is to say, planning, implementation, and evaluation. While respondents were familiar with most of the concepts used to carry out the study, they stated that the tool should help raise or rekindle stakeholders' awareness about those issues. Depending on their role, areas of responsibilities, and level of awareness about equities in health, participants identify a number of uses and objectives for the tools: a memory aid, an analysis grid, a checklist, or a tool for advocacy to address social inequalities in health. However, some participants disagreed about the tool's ultimate purpose. For a number of them, the tool should be mandatory, results-oriented, and thus aimed at taking quantitative measures of potential effects. For others, it should simply be used as a working tool in support of a partnership approach. In their minds, the tool should be used on a voluntary basis. Slide number 20. Despite or perhaps because of, it depends, the variety of roles and concerns of stakeholders involved in an intervention, the respondents wanted a universal tool that could be used in any context. What they wanted is a general and multi-purpose tool which can be applied to various areas of health promotion activity, and a tool that can be flexible enough to be applied at the various phases of an intervention life cycle, preparation, planning, implementation, and evaluation. This versatility also refers to how to answer the questionnaire in the tool, in project team, with partners, or with recipients, and how easily it can be incorporated into current practices and priorities. Next slide. Although respondents appreciated the tool's questionnaire format, they found that the numerous aspects to be considered could be unrealistic given their heavy workload. They recommended to shorten the grid, divided it into subsections, project phases, and project phases. Subsections could then be used independently depending on the needs or a project progress. Terms or concepts that were found to be too theoretical or academic were perceived as a barrier. Given the prevalence of bilingual settings, it was important for the participants that an English version be available. Respondents also highlighted a lack of guidance on how to use and complete the questionnaire. They strongly recommended that we develop resources and guidelines, for example, a glossary, a user guide, a checklist, or even case examples of how the tool was applied in some projects. In addition, respondents also recommended to provide training sessions and/or technical facilitation. Next slide. Based on these results, a steering committee composed of researchers and regional, local, and health promotion practitioners worked to iteratively adapt and validate the tool. During this process, we tried to simplify the language while identifying and removing items that were too similar or overlapping. We also focused on the tool's format and design. Each new draft was submitted to diverse local and regional stakeholders who were asked to provide feedback on a series of elements: wording, content, structure, length of the different sections, and user-friendliness. Once we reached a consensus on a particular version, we tested the tool. We examined 2 interventions at the local level and 2 more at the regional level. Each analysis involved in-depth interviews with the team in charge of the intervention. The feedback and information were incorporated into a final version that was validated by a number of possible end users and into a framework well adapted to the realities of practitioners and organizations working in various areas of the public health system in Quebec. Next slide. The tool's name in French, Reflex-ISS, highlights the importance of having more systematic collective discussions around health promotion and related interventions so that social inequalities in health are addressed. To view an introduction of the tool, please click on the link provided in the tool's web page, and then I'm waiting for downloading. I don't know, it doesn't work for me.
So I clicked on the tool, and I think we need to scroll down once the web page opens. Scroll down, and there'll be a box which says, I'm still waiting for it to open here.
Is it okay?
It's taken a little bit of time to load on my screen. I'm not sure if other people are there yet. I see a few people writing in the chat box. Okay, so some people are having some trouble accessing it.
Yes, I don't succeed to.
So I know the link works because I was on the website this morning. So we can try. You can try the link later on your own. Exactly. Some people were saying it was working yesterday.
So I continue?
Yes, please.
So today the grid includes 5 sections, each covering one phase of a project life cycle: planning, implementation, evaluation, sustainability, and empowerment, which is perceived as a key intermediary result in the reduction of social inequalities in health. Within these 5 sections, 44 discussion items are presented as questions covering elements that have been identified as important to the success of actions implemented to resolve social inequalities in health. Although the format is linear and structured to reflect each phase and the list of questions might suggest a top-down directive or normative approach, the tool is in fact well adapted to a dynamic perception of health promotion interventions. Most of all, it encourages project teams to discuss and reflect among themselves. It's not a prescriptive tool. For each discussion item within a section, the team has to assess on a scale of 0 to 5 to what degree the item was in fact considered or addressed. It is important, very important to mention that this rating scale is in no way intended to assess the team's performance, but rather to stimulate the conversation between stakeholders. The tool deliberately covers practical measures, that is to say, measures that make sense to those involved, that are useful and usable for frontline practitioners to assess their progress. Next to the rating scale, space is provided to include comments on the reasons behind the rating, any specifics about measures acted upon, and details about the intervention context or processes that have helped or hindered the action. And at the end of the analysis, you also can receive the report of your work by mail. We move to the slide number 24. No. 20. Excuse me. Okay, 25. Before to conclude, a word on the framework of use. First, the Reflex-ISS is not designed to evaluate a team's outcome or a team's performance in addressing social inequalities in health. It is not designed as a normative approach or to give positive or negative marks to a team. It is not a guideline to follow to know what to do or how to do it. Reflex-ISS was created as a work tool for teams. Its goal is to help start and maintain an open conversation between stakeholders to help overcome obstacles and take effective and pragmatic decisions about what actions are needed to address social inequalities in health. What is important is not the answers to the questions, but the process of reflection between partners. Next slide. The tool is for a variety of stakeholders or actors involved in the planning, implementation, or evaluation of a population health promotion intervention. For example, managers, professionals, volunteers, government representatives. Next slide. The tool can be used to make adjustments to an existing or a planned intervention at any stage of its life cycle. The tool aims to reflect on the consensus-building approach needed to strengthen the ability to address social inequalities in health by engaging in collective and collaborative action. On a more modest but important level, the Reflex-ISS tool can be used to identify which advocacy arguments are needed to mobilize partners in an effort to address equity in health. Next slide. After our study, we recommended that a reflexive analysis be done with a maximum of stakeholders engaged in the intervention. To facilitate discussions between stakeholders that have very different knowledge and experience about equity in health, it is best that teams call upon a facilitator with sufficient knowledge about social determinants of health, conceptual issues, theories, methodologies related to social inequalities in health, and maybe group facilitation competencies. In addition, we recommended to carry out the analysis in support of a larger method instrument, including in-depth discussion, which are the only ones that can bring out qualitative aspects of a given project and help stimulate a reflexive analysis of teams in action. The tool, even if it is flexible, should be used in its entirety so that teams examine social inequalities in health in detail and avoid a working climate focused on performance. Slide number 29. The Reflex-ISS tool is offered in French, English, and Spanish. The promotion and knowledge transfer activities cover the following: an interactive tool in PDF format, a web-based tool, a user guide including a glossary and examples of practical applications, some workshops, a training is being developed, but only in French. You can access most of these resources by clicking on the previous hyperlink. Next slide. Our experience using the tool these last few months has led us to believe that it is unique and complementary to the array of available health equity tools. Its advantage is that it provides a holistic approach to more complex interventions within public health and requires stakeholders to support critical and progressive reflexive thinking throughout the lifespan of the intervention. In the context of Quebec realities, Reflex-ISS is now considered as a tool that could support the implementation of the new National Public Health Program, as well as the governmental policy for health prevention. Within these two mechanisms, addressing social inequalities in health is a priority for public health action in Quebec. Next slide. Using Reflex-ISS in the evaluation process of a number of interventions carried out in Montérégie has helped validate its relevance and usefulness and its ability to foster discussion between partners on social inequalities in health issues. Karen will discuss this afterwards. However, our findings clearly show that applying Reflex-ISS requires some form of support to help teams carry out an in-depth analysis that will lead to significant changes in their practices. The fact that public health organizations need to consider supporting teams who wish to use the tool is key to the integration of the tools into practices, and it will be the focus of our work for months to come. Thank you for your attention. If you have any questions, I can answer it at the end of the current presentation. Thank you.
Thank you very much, and it's really great to see the amount of thought your team put in terms of ensuring participation from the organizations who are going to be using this tool. As Anne mentioned, we will be taking questions at the end of both presentations, but you can start to send them in via the chat box. We're now going to move on to slide number 34, and I'm going to pass it on to you, Karen. Karen is going to talk about how this tool has been applied in Montérégie.
Thank you very much. I don't have a text, so it's more improvisation than Anne, but if you have questions, please write them down, and I will try to answer as well as I can. So we tried a tool in Montérégie because we were in a context where we noticed that a lot of action that were planned to address social inequality were put in plan, but were not, in fact, implanted. And when we were talking with different local and provincial and regional actors, there's a lot of people were saying that they had the perception that there's too many obstacles to act on social inequality. They felt like they don't have the competency to do it, they had the ability to act, they don't have the knowledge, or the perception that it's not their role to act on social inequality. So in Montérégie, we were, I'm going to the other slide. In Montérégie, we had the request from different public health actors to address this topic. They want to intervene, and they want to know how to do it. So in the regional public health department, we did some work to try to find what kind of tool can be put in place to help them to, in fact, really intervene on social inequality. We did find a lot of different tools, but we were really looking on a tool that was more a reflective approach. So a lot of more thinking about what they're doing, how they're doing it, and how they can be better. We were not looking at a performance tool at all. We didn't want to have an evaluation tool either. So the only tool that come up, and that was in French because we're in Quebec, was the one tool that was developed by Anne and Valérie Reed from University of Montreal. But the tool was really interesting, but still a little bit complicated for our context. And Anne just told you about all the story of how we create the Reflex-ISS tool and the condition to use it. And it was helpful to create the tool with researchers because public health actors that need this tool were in fact implicated in the creation also of the tool. So that was the first, how can I say, a first start to make them happy that the tool is coming and make them involved also in the tool. So there was a creation of the Reflex-ISS, and then we went to validation of the tool and development of all the different instruction package and everything that Anne told you about. And we were in 2016 of the integration of the tool in Montérégie, and we decided to do it in the public health unit at the regional level. So I will go to the other slide. That's the tool, in fact, that is when you will be able to find it, it looks like this. So we decided to train the regional actor and not for now the local actor, because in Quebec we have a regional actor that are in a public health unit, and we have local actors that are more on the field, so more at the CLSC levels that act in public health. And we decided to start with the regional one because in our role we need to accompany, we need to be there for the local to help them do their activity. So we have to be convinced and equipped in the regional level to be able to do this pairing with the local level. So the step number one was really to try to facilitate the application of the Reflex-ISS. And we did in different phases. So we plan, we train, we try to integrate, we want to evaluate, and we want to see how we can do it for a certain sustainability of the tool and the knowledge. So if you go to slide 39, the first thing we did is to plan the action and to really think about what we're doing. In 2015, there were the public health program, the Quebec Public Health Program that went out, and the social inequality is one of the main themes of the public health program. And in Montérégie, we decided also in our regional action plan that it was one of the main preoccupations that public health actors, local and regional, have to focus on for their action. So the position of social inequality, it was a priority, and it helped us to bring all kind of actors in the same way we want to go in a way to act on social inequality. We also try to develop, in fact, we developed a training on the approach, on the reflexive approach, and on the tool. So that was something major we did last year to try to really equip our actor in this field. Also, we did try to bring all stakeholders to discuss of the urgency to act on this theme. We also make some adjustment in action plan to try really to implement the tool And we use the tool and the approach to mobilize action to address social inequality. So we really position this tool and the action as something really important. However, while planning, we still have some people who saw a lot of obstacles in using the tool and the approach. The tool is still perceived as really long to do and maybe a little bit complex. There's a lot of people who have this resistance to change, and we still have the perception that is not in their backyard, is not their role. So we really act now to change those perception. There's a lot of work that is doing now in Montérégie to make social inequality in the backyard of everyone, every team, every professional. Even if you're in protection, prevention, you're in different position, local, regional, is in your backyard. So the message that the Directrice de Santé Publique, so the Public Health Directress, is saying is it's the role of everyone. And we try to really stop all this, not stop, really to work on how they perceive the tool. Maybe it's long, but it's long because it's a tool that brings people to think about their practice, to talk about their practice. So it's not long to take a pause and to talk about what you're doing and to see if you're in fact increasing maybe social inequality by your action. So there's a lot of, how can I say, talk about to try to stop those obstacles or perceive obstacles by a different actor. So that's the first part we're doing, the planning action. We're doing right now the training of public health professional. In fact, we did an experimentation or pre-test of the training because we were really preoccupied that the training will bring people to use the tool. So the training has as objective to increase the commitment of people, to increase the knowledge, to increase the competency to use the tool. And a lot, we give time for the training. We had the vision about it, and still there's some obstacle, but it's changing really fast because people start to see the merit of the tool and the merit of the reflective analysis. We have coached to help them change also their perception, and even though they still think there's a lot of competency to use the tool, we had an example of someone who is using it every day or almost every day in one of the local units we have, and by his testimony is bringing the fact that every time you're using the tool, it's getting easier and easier, and now he's not even reading the things. He's really able to do an animation without having all the tools with him. So it's getting easier with time. So the training was experienced, and we did some modification to train other public health actors. So we're now in the implementation of all this. So we'll do training of all public health actors in between 2017 and 2020 because it's in our regional action plan. We do a lot of training on social inequality. So we did the webinar last week on social inequality. All people will follow the webinar in French on the Reflex-ISS tool. We put it as a priority. So we're getting more and more people involved in the tool and in the approach. And one day we hope we will evaluate the tool and evaluate how we did with it. We want to do a process evaluation to see how many professionals at the regional level were trained, eventually at a local level also. We want to see in fact, how they find the relevance of the tool, the usefulness of the tool, how they're satisfied with the tool. And ultimately, we want to see if it's responds to the need and if it's a good approach to really think about social inequality and act on social inequality. So sustainability of action, we hope in Montérégie that it will stay as a regional priority. by doing the electronic tool, the web and everything, it's make it easy for everyone to use it. And we still need to have time to promote the tool, to coaching, to make all the training available for everyone. And even though if it's not already a priority for collaborator, we need to put more effort to make them also their priority, not only in public health unit, regional or local, but also in a priority for all the collaborators that we have. Thank you.
Great. Thank you very much, Karen, for that. We have a few questions coming in, which we can start to get to. And I know a few people had some trouble getting onto the website, so we're going to try and see if we can pull up the website during the course of the Q&A. So we're experimenting here. We hope we don't lose anyone, but we'll start with the questions. So Anne, the first question is for you, and it's a question of clarification. The question is, what is the maximum number of stakeholders? So during one of your slides, you talked about the importance of involving the maximum number of stakeholders.
To use the tool, there is no maximum of stakeholders to analyze an intervention.
Okay, great. Thanks for that clarification. The next question is about the development of the tool. So the question is, the tool is useful at the regional level and at the local level. How was the team able to find compromise that could fit either level?
Okay. We really didn't need to accede to a consensus because it was what they want. They wanted only one tool for everybody at the regional and local level. They really didn't want a multiplication of tools. So what it happened that, for example, the regional level just use section for the planification of an action, and the frontline practitioner use the other section. It depends on the progress of the action. You use the section related in the project development. You can choose what you need to address.
Great. Thank you for that clarification. Okay, so keep sending me your questions. We're just trying to pull up the tool right now, so I'm not sure if people can see that. I'm sharing my screen. If you're able to see that, just respond in the chat box so we know that it's coming up for you. Okay, I see a few comments there. Yes, we can see it. All right, great. So, Karen, I was wondering if we could just look at a few of the questions in the project planning section. So
okay, that's the project planning of the tool. When I was talking about project planning, it was the project planning of how we implement the tool into the public health unit. So it's not the same planning we're talking about.
Okay. So thanks for clarifying that. So for your team, if you were going through this tool, the first question there would be something like, so under the project planning section, it says, elements to consider and address. The first question is the nature of the problem of social inequalities in health and the problems experienced by the different target subgroups of the population concerned by the project have been clearly described and defined in the project.
Exactly.
So, okay, and so your team would have an opportunity to say yes, it's been considered, a discussion has been initiated, or concrete actions have been proposed.
Exactly. When we did the pre-test of the tool, we chose a project was I don't know how to say it in English, les centres d'abandon tabagisme. So it's Center for Helping People Stop to Smoke. Okay. And there were 5 people around the table, and it was all the main public health actors that act on this activity. And they have to do the reflection each by themselves, and then we talk if while they were doing the program and defining and describing the program, did they have the the thinking about the nature of the problem of social inequality and the different target subgroup. So while everyone were kind of looking at what they thought, after you compare the score of everyone and you discuss on the score of everyone, and then it gives you an idea of if social inequality was considered in this particular question, so if concrete action were undertaken or not, and then if it was good, that's nice, but if we noticed that, oh my God, maybe not really concrete action were done, in the comments, it gives you the height to say, maybe we need to look at this. So it's how we did use the tool on a specific project.
Great, thank you very much. Okay, so we have a few more questions coming in. I'm going to stop sharing that. I'm going to come back to the main screen. And so we have a few questions coming up for our presenters. I'll bring the slides back up. So I have a question coming in from someone who's based in Quebec. The question is, how does our public health team become trained in using this tool?
For now, we did only one team, that is the team that is focusing on safe habit. I don't know how safe and healthy habit. So we did the pretest of the training with them, and we had their comments. So in our action plan, all the different team of the public health unit in Montérégie will be trained on to use the tool for their different project with their different partners. So we have an action plan where we know that we still need to work a little bit on the training, and then during the next year, all the people will be trained group by group about how to use the tool, but not only the tool, but the reflective approach also.
Great, thank you. And Anne, is your team providing support? You mentioned you're doing technical assistance, so is that support available to public health units within Quebec?
Yes. The problem now is that we didn't have enough money to support all the team. Ask us for training, so we look for to get a subvention to develop a training and an assistance in a reflexive manner to support all the teams that ask for assistance. So for the moment, we just organize some kind of workshops. We sensibilize to the tool, and that's all.
Great, thanks. And you can get the information for the project team is available on the website, so I think if there's interest, you can let Anne and her team know, and when resources are available or when they're offering other kinds of trainings, you can find out about that. So we have two more questions coming in, which we'll try to take. We have a few more minutes left here. The next question is about the values and the context within which the tool was being introduced. The question is, how did Montérégie set the values or the social justice context for the training to introduce this tool? So I'm wondering if Karen, you can speak to that.
In fact, I'm not sure to really quite understand the question. Maybe just to have a clarification of what exactly the person wants to know, because it was kind of easy to introduce the training to the tool because it was put as a priority in our original action plan, and our new directress focused on social inequality in our fellowship. So it was just a continuing of what she was thinking was the best for our population. It's in our value as an establishment to really address the need of all our population with a focus on population that might be forgot or might be not well served, with also the gradient of inequality in our mind. But to put the okay, I see did you some conscious raising? Oh, yes, for sure there's a lot of conscious raising in the training. It's kind of the first part of the training is really we're starting the training with saying, what are you doing now for social inequality. And people do a lot of things, but it's always little things, and it's not transversal. And it's not as, I don't know how to say, but as reflect the really main component of social inequality, like the structural determinant of social inequality. So we try to raise consciousness at the beginning of saying we're doing a lot of things, but for now we're not doing enough. And it's not only the team in health promotion that is supposed to work on that, it's your responsibility also. And we start with a lot of surveillance data and a lot of literature to prove that it's a problem that has to be addressed by everyone. I don't know if it's clarified, but that's how we try to put people in the minding of changing their behavior, not their practice in regard to social inequality.
Great, thanks for that. I think you answered that question based on the comment coming in the chat box. We have one last question, which is, so someone would like to know if this tool has been implemented with health protection or environmental health staff yet. So what has it been used with?
For the moment, we didn't use it for health protection, and I think it's when we work on health protection and measure and indicators, it's more difficult to use the tool. The tool is adapted for health promotion interventions, you know. So we engage a reflection with the INSPQ, l'Institut National de Santé Publique au Québec, to see if l'équipe surveillance is
surveillance team?
Yes, if surveillance team will be interested in this tool, and for them we have to adapt it for this team in particular.
Yeah.
But I think it's okay. We can use it without problem for environmental health.
Yeah, for sure.
Great. Thank you. I think it would be interesting for people on the line if you're thinking about applying this tool to your work. Like if you do apply to different programs, I'm sure Anne, Karen, and the rest of the team would love to hear about how you're using this team and your experiences and how it's changing your practice. Okay, great. So I think we got through all of the questions. I'd like to thank our presenters, Anne and Karen, for being on the call today with us and for really sharing the experience. We encourage everyone to go to the website, take a look at the tool itself. On the website, you'll also find a number of case studies. I think there are 2 case studies right now about how this tool has been applied in other programs. And so to wrap up, we'd just like to get a sense from you. After going through today's webinar, can you start to think about how you can apply this tool in your work? So you can either respond yes and please share how, or yes and you need some more support, or you don't think it's really relevant. I see Karen Rideout is saying she'll be interested in knowing how it's adapted for environmental health teams, so that's one potential application. Thank you. And if you don't think it applies to your work, we'd also love to hear why you think that. Okay, great. So we're seeing here there's a combination of some people can see direct application, others can, but we need some support. So before we close, Anne, there's just a quick question there. Once you complete the questions in each section, are the results generated by the tool itself, or do you need to determine them ourselves? So this is a question about the online version.
If we can return on the web tool, is it possible?
Okay. It is possible.
Everything is possible with this.
Not everything, but we try to do some things. Let's go here. Okay, we're back on the tool.
So, Reflex-ISS is not a measurement instrument, so we don't want to give a good or bad marks. So what we found I tried to go down. You have a section, I can't go down, but at the end of each section, you can Yes, here, for example, you have a red, yellow, or green card, and you can do an estimation of your evaluation, of your analysis. It's not a note. So you can say, okay, we are good. We put us in the green. Oh no, we have to do more. We have to engage something, and you put red, and then you can plan action. You can plan action, suggested improvement 1, 2. So the system does not generate a note, a mark.
Okay, great.
Clear?
Thank you for that. So we are just at 2 o'clock right now. I see there are a few questions coming in, or some comments. If there are any more questions, we'll try and respond to those by email. We're just going to go back to the presentation here really quickly. So we are going to be sending out an evaluation shortly. There's also a link on your screen, I believe, if I can pull that up again. Okay, we're just reloading the presentation. So again, I'd like to thank Anne and Karen for joining us today. As I mentioned, this is the first of a webinar series on health equity tools, and more information is available on our website. And you can also join us next month for a webinar looking at upstream solutions to food insecurity. So thank you all for joining us, and we look forward to hearing how you are using this tool and other tools in your work. Thanks, Anne. Thanks, Karen.
Thank you.
Very much.
Great.